Brandon George is a vice president for Recovery Advocacy and Programs for Mental Health America, Indiana, and the director of Indiana Addictions Issues Coalition, which advocates for recovery through public policy and education. As a person in long-term recovery, Brandon dedicates his time personally and professionally to fighting addiction and promoting recovery. Brandon helped create a recovery ecosystem in Indiana that consists of over 20 recovery organizations that serves 92 counties. That is fantastic. He has been used as a consultant for SAMHSA's Opioid Response Network, the Bureau of Justice Assistance, and is a contributor to Harvard's Law blog. He has served as a trusted advisor to the National Judicial Opioid Task Force, on Leaders Council for Legal Services Corporation, and recently spoke at the White House for the Office of National Drug Control Policy regarding addiction, workforce issues, and recovery messaging. Thank you, Brandon, and welcome.
Thanks, Kimbra. I appreciate it and appreciate the time to hang out with you all. I was able to present with Doug not too far back. We got some feedback that folks wanted more information. One on the Journey Home project specifically that we've been piloting in a handful of counties around the state that focuses on folks' journey home from inside of corrections back into their community. And then also a legislative preview of what's coming for the upcoming legislative session. As most folks know, Organization Day was yesterday, which is technically the start of the legislative session, even though we really don't get to doing anything till the first week of January. And so the Indiana Chamber, the caucuses, everybody's starting to put their agendas forward. And that includes us in the mental health and addiction space as well. And so I want to make sure that everybody on here, specifically because of your roles, is up to speed on what's going on in these spaces, because it's really important. And so I want to start off by touching on Journey Home. And I'm going to throw something up on the Al, do you have the Journey Home screen or my Zoom screen?
Yes.
Perfect. All right. So I just throw a slide up so that you guys can see some bullets around what it's focused on. But essentially, Journey Home started about a year and a half ago, and it was born from a group of people looking at some of the ways that could be most impactful for helping our overdose rate specifically. And so I don't know if anybody saw the numbers that came out today. I don't repeat these a ton just because I think they get repeated too much. But these are new and they're startling, and everybody needs to know the 12-month period from April of 2020 to the end of April of 2021. CDC is estimating over 100,000 overdose deaths. 100,000. And so to give comparison, we were about 72,000 in 2019. Indiana had just had about a 10% decrease, 12% actually. The national average was almost half that, and Indiana was doing a good job. Everybody was kind of patting themselves on the back on the strategies we had put forward, what the governor's office was doing, the state, et cetera. We knew that 2020 was going to be bad. But I don't think anybody recognized how bad it would be. I think that COVID and isolation, et cetera, really affected people's ability to be connected and get treatment and resources. And so you saw overdoses go up by over 30% across the country, and Indiana went up by 35% in 2020. And so any momentum we had gained in the previous year, we gave it back in 2020. And something startling happened to me a couple months ago in the fact that, so these numbers came out, like we had numbers that said it was going to be around 96,000 and then 99, which was this 30% increase or a little bit higher. The thing that I wasn't prepared for, and I don't think many people know right now, is that that's 2020. And so 2021, we're actually seeing another 20% increase. As of the end of about July or August, they were looking at a 20% increase. And that's not 20% increase off the old number. that's 20% off the increase of 35%. And so anybody that knows how percentages work, 35 one year and 20 another year, that's not 55% increase. It's much higher than that. You have the 35, which brings the number up to almost 100, and then another 20% of that. And so you're talking, from 72 to, possibly, well over 100, 110, 120. So you're talking about 70, 80% increase over a couple of years when you add those together. And we got to do, like, we have to do something. And so Journey Home was born in that space of overdose crisis. What are some areas that we can really, really dig into? And so United Healthcare actually is the insurance group that started pulling people together. And they got some state leaders together, and a couple spaces that they ended up landing on were groups that had really, really high overdose rates or were at the highest risk of overdose. And what they teased out from that is that folks leaving correctional settings, specifically county jails, were at a much, much higher risk of overdose. There was a study in Massachusetts, I think, that said that folks were 120 times more likely to die of overdose leaving a correctional setting. And that's for a variety of reasons. People go to jail, they don't they lose their tolerance, they use the same amounts. Also, the drug supply changed. People go to jail and come out, and all of a sudden fentanyl is part of it, and they're not used to that. And so there's a variety of factors that go into it, but nonetheless, folks leave in jail at a really, really high rate of overdose. And so this group that consisted of United Healthcare, Indiana University School of Medicine, and the Rural Health Association, Department of Health, we started putting together a plan on how we could possibly do that. We got brought into the conversation a little bit over a year ago, mainly because of my experience in my previous life of work in the criminal justice system, of implementing a lot of programmings within county jails around the state and around the country. And this space of trying to help people leaving jail into community is really, really hard. Like, you're at this intersection of public safety and public health that is hard. Like, we have to make decisions on, like, keeping the community safe, but at the same time trying to get people the help that they need. And those lines just get really, really blurry. And so a couple of things that we know is that people come in and out of county jails very fast, right? They can bond out at any time if you're pretrial. And so there's not these scheduled release dates like there is for a prison. For those of you that aren't familiar, people in prison, they pretty much have a release date, and you can plan accordingly. Well, jail's not the same case. Like, bonds can get rid of people. Family may not have money to bail a kid out one day, but in 3 days they do. And so you've really got this transient population coming in and coming out. And if you try to help people on the way out the door, you've missed the mark because they just disappear. Like, one shift just comes in and the guy's gone because he's bonded out or got released by a judge. And so part of Journey Home is figuring out how to shore up that solution. And part of that is helping identify people that need support on the way in. And so one of the things that we're doing is we've got technology in place so that when people come into the jail, they get handed an iPad. It's got a brief self-reporting assessment about addiction, right? Are you going to go into withdrawal? Have you had addiction-related issues in the past? Do you need help finding a recovery house or a recovery coach? And so there's this assessment piece, and they take it, and if it scores a certain amount, it sends an email to the organization that provides recovery coaches. It sends an email to the jail medical staff, and it also sends an email to the jail captain and then the sheriff, right? Because everybody knows when the boss is on the email, we all pay a little bit more attention to it. And so this mechanism, so that people, right when they get in, we can identify them and then have a peer support start working with that person from the beginning, not trying to cram stuff in at the very end. And so a couple of reasons that that's important. It's really common practice in a lot of our counties. A lot of our judges will release people if they have a safe place to go, if they can go to a recovery residence, et cetera. And it's hard to figure out the logistics of that from jail. And I don't know how many people in here have experience in the criminal justice system, but it's not like you don't just have your cell phone there where you can like Google recovery residences, right? Like all of that stuff's limited. If you don't have money, sometimes, several dollars, $20 a phone call, which is ridiculous, by the way, you can't access the outside world. And so you rely on things like writing letters. Could you imagine, like, think about this. If you need to, like, I don't know, get a haircut or your nails done or something with your insurance company, could you imagine pulling out a piece of paper and a pen and writing a letter to that person and mailing it to them and then waiting on a response? Like, that's absurd. Like people don't even check their mail like that. Like most people don't even, like, they're not looking for communication that way. And so half the time people, like, a month or 2 months, they're like, oh, what's this letter? It's from somebody in jail. Oh, wow, they're looking for something. And so the idea first that that's a good method of communication, like we all know it's not. And then like the idea that somebody's going to receive it right back, et cetera. And so people are in this position all the time. Like this is not, I'm not cherry picking some outlandish situation. Like this happens every single day. People will write 15 letters to 15 different recovery houses, hoping somebody will respond. And that's just not an efficient way to get people help. And so having a community-based group, and whether that's a recovery coach, or in our instance, you can do a recovery coach or a paramedicine group. Crawfordsville and some other groups have these community paramedicine programs to where they've got paramedics out in the community that can help. And so you can do either one in this Journey Home program. Most folks have went with recovery coaches for two reasons. One, because they're resource brokers in this space, they're very familiar with a lot of times both the criminal justice setting and the recovery resources available. But then the other piece is that, the thing that makes recovery coaches uniquely qualified for this or helpful is that they're able to earn trust of the folks that we're helping in a really short amount of time. Like a lot of folks that are in these situations have relationship issues, they have trust issues, et cetera. And especially when you're doing services inside of a jail, they're always skeptical. And so having a recovery coach that can identify with them and earn their trust in a short amount of time is really a critical piece of the pie, because we don't have weeks or months to help build that type of trust up. We have a matter of minutes, days, hours, et cetera. And so the recovery coaches are really uniquely qualified there. And so we start connecting with the recovery coach to start helping identify the areas that they may need help as they transition, healthcare being one of them, treatment, housing. We just talked about that with recovery residences. They may need support in job-related stuff or education, or recovery supports and meetings, getting set up with ongoing support in the community. And we've got some really good programs inside of jails, and we've got some really good stuff in the community, but rarely are they really tethered together for a good, what we would call continuity of care. And Journey Home, the definition of that is to make sure that we bridge that gap. And so the three pilot counties that we are working in, Boone County is one, Delaware County is another, and Daviess County is our third. And all three of them are at different stages. Daviess County, Boone County has several really good programs, and they're already implemented that assessment piece with the peers on the way in. Daviess County is in the process right now of doing that, and Delaware County, we're still a little bit more in the planning stages. And so we've got the one aspect where we've got peer support helping people that we've identified through the journey, but the other part of Journey Home, and another really important factor, is the coordination, the increase in collaboration between providers. And what I mean by that is, if most communities I walk into have a provider or two, and when asked if they work together, they say yes, but it's not really something that's formalized. There's no MOU in place. There's not like an agreement that, hey, if you send me a referral, I respond to them within 24 hours, right? Or within 48 hours. And so trying really to increase that. So instead of having somebody wait 6 weeks to get services with one provider, can we get them to a different provider to get help a little bit sooner? Because when you're in a crisis, or when you have an active addiction, waiting 6 weeks it's just a lifetime. I mean, we got people that need help and need it now. And so part of this also is getting people plugged back in with insurance, I don't know if everybody's aware of this, but if you go to jail, your insurance gets cut off. And the county does everything while you're in the jail. The problem with that is when it gets turned back on, it usually takes 30 days to get turned on. And so even if you get somebody the day they walk out, it's going to be 30 days before their insurance is active. And so some places will work with you and do stuff in the meantime, some won't. But could you imagine just needing like your regular blood pressure medication and not being able to access it for 30 days? It's really an archaic system. And actually, it's going to lead to some of the policy conversation that we have later on about this around making sure that people that are incarcerated have access to payer sources, insurance, et cetera. It's a benefit to the jail as well. The jails pick up the whole tab for everybody's medical expense at the county level. And so there is no insurance for these folks, which places a big burden on both the county, all of us as taxpayers, and it doesn't solve the problem. It creates an additional problem. And so helping streamline some of this process from getting people on insurance, making sure that people in the community are collaborating more efficiently is important. So that people aren't dropping through the cracks. And something else that's noticed, kind of what we did in each county, so that everybody knows process. And in case you want to do something in your county, the hope is that we'll be able to roll this out to a variety of partners. But the way that it worked is that we initially have a meeting with the with the sheriff to make sure he's okay with, doing programming inside the jail. Then we talk to the judge to get the judge's blessing. The judges don't oversee programs, but you want to make sure that they're okay with something like this in their program and that they support it in general. And so we have a meeting there. And then we broaden out to, I would say, like the first, kind of intimate, the inside circle of who provides services: community corrections, the public defender, prosecutor, other treatment providers, RCO. And then once that's established, a meeting with the full community so that everybody knows what's going on and we can help coordinate that collaboration between the different agencies. So we're really excited about it. We think that it's a way, criminal justice system is the largest referral source for the treatment system. I don't know if everybody knows that, but I mean, the vast majority of people incarcerated have mental health or STD issues. And so finding a way to improve this, we think is really important. So I'm going to stop there. I want to get into some policy conversation. Kimber, do you want to take a second? Should I take a second for some questions now, or do you want me to go into policy and do it all at the end?
I think it would be good to go ahead and ask questions now if people have questions about the journey home.
Feel free, unmute yourself and just go ahead and ask the question, or you can put it in the chat box.
I have a question.
Go ahead, Nicole.
How involved are core alcohol and drug programs in your discussions?
Vary where they're applicable. So Boone County has a new one that's getting up and going.
Well, it's had it for a long time, but they're separating, yeah.
Yeah, into the family. And so they're going to be, they're definitely part of that. We're part of that conversation with the magistrate and the judge that's in Superior One about what this looks like. And so very involved. We have, so I guess something else to mention with the kind of the advisory group that started all this, it's grown significantly to make sure that the program is in line with other state programs. And so the Supreme Court or the Indiana courts is part of that advisory group. So we can have the conversations about problem solving courts, and then also about Rule 23, right? Like that's a big deal about making sure that people are getting back out into community when they're not a safety risk. And so we didn't want to jam that up either, right? We don't want a judge to say, oh, well, you're meeting with the recovery coach, so you should stay in there until they, you're done with them. We don't want to do any of that. So it was really important to us to make sure that all these programs are complementing one another. It's not a displacement issue or competition. It should be viewed as a way to support other things. If you really think about with recovery coaches, they are really more of a glue and a resource broker, not, they're themselves a program or treatment provider. And so really see it as complementary is the word I would use.
Which counties are you doing your pilot again?
Davies, Boone, and Delaware. And the reasons for that, just so you know, is what we did is we asset mapped the communities that have specific resources specifically for addictions care. And so like normally you wouldn't think of Boone County as a high resource county, but they've got an enormous amount of programs and things going on with the state and federal government. So we consider them a high resource. Delaware, kind of in the middle of the ground. They have a lot of new programming there. It's not matured yet. And then Davies County really being a low resource rural area with much more of a lack of resources. And the goal was so that we would have kind of three different models, right? So that if you're a county, you're in Greene County, you can look at these three and say, okay, well, we're more like Boone County or Delaware County, and have the goal at the end of this will be to have white papers on each of them to identify the barriers and successes in each of them, so that people that want to duplicate it have somewhat of a roadmap.
It's just my concern with any of these types of programs is the core alcohol and drug programs are specifically designed to deal with some of the issues that you're talking about. And when they're not included in the conversation, sometimes that is kind of a barrier for the program trying to come in and start services. So that's the questions I asked. I'm the core alcohol and drug director in Greene County. That's why I ask. We just actually had a meeting with recovery works prior to this. So that's why I was asking those questions.
Yeah, you're absolutely right. And that's also when we start talking about kind of like how this unfolded and who you bring in. That's why, like I said, sheriff number one, because it's his house, so to speak. And if you're going to have dinner at his house, you got to ask him. But
Right.
The courts are immediately the next piece of that, right? Because you start hammering out what you're talking about there. What else is involved here? And what are the other pieces that need to be the table? Because I think the hope on our end is really, coordination and supplementing or helping what's existing there, right? And then how do we bring in existing payer sources like Recovery Works, other things that can help with sustainability too, right? Because if we gave all these counties $1 million and created an amazing program, Nicole, you'd look at me and say, well, I could do the same thing if you give me $1 million, right? Like that doesn't, that's not how we're doing it. So we're really trying to use existing resources for the most part. And if there are very specific barriers we encountered, then we're trying to find a way to overcome those. Like one of the Davies didn't have any recovery residences. And so we got together with the Oxford houses and some other folks and encouraged them to have some conversations out there.
Davies County has the Lighthouse Recovery Center.
The faith-based one. Sorry, they don't have anything that's not faith-based. That was one of the things that they had specifically asked for. But but those types of things, right, that are like really like Boone County was having a problem with employment-related stuff. So we got the Indiana Chamber and their workforce recovery to come work with some of their employers, like trying to make those types of overcome those pieces. Another one had a stigma issue, so we tried to redirect some of the state's stigma campaign to a specific area. That's kind of one of the ancillary benefits of having kind of this advisory group with all these different state agencies, is that it's not so much that they're throwing like new money or resources, but they are able to kind of divert existing programs, right? Or say, hey, I've got a relationship here. Maybe we can focus a little bit more on this county. And so it's been beneficial, and I hope it will be for the entire state, not just these pilots. The hope is other people want to do it, and we still kind of have this core group that can help make sure people overcome some of the things that pop up.
How long do you think the pilot programs will last before you know what's going to happen next?
Probably through next year, till we have some real data back on it, on what's happening with it. And so that's what I would say. I would hope next year I'm presenting on this and telling you guys that we've got 3 things up and going. These are the things going great. These are the things that are struggles. And, we're taking essentially applications to do more of it is the hope. And that may happen sooner. If there's we're looking at expanding some funding. And if we get that, we'll probably go ahead and open it up to some other folks, so we can have some of that preliminary conversations that we're talking about. Because if I'm being honest, just full transparency, the politics in the community of getting it going are much harder than the actual program implementation. So it took over a year to have those conversations I was just telling you about, right? So the county commissioner and judge and sheriff, and some people get along, some people don't. It takes a while.
Thank you.
Mm-hmm. Anybody else? Any other questions? All right. If anybody does have any other questions, feel free to put them in the chat box, or we can circle back around to it. It doesn't have to be a dead topic, if you will. But I do want to go ahead and start getting into some legislative pieces. Couple things to note for anybody that's not super familiar with how our legislative cycles work here. Indiana does its budget on a biennial basis, which means that we do the budget. We did the budget last year, and it was for this current year that we're on and the next year. So they do a 2-year budget at a time, which is so we have during the budget session, it's what we call a long session, and then it lasts for somewhere around 16 weeks. And then in a short session, which is what we have upcoming this year, where there's no budget attached to it, it's only going to last somewhere between 10 and 12 weeks. And that's because there's no money stuff to figure it out. The good and bad, the good, it makes for a little bit smoother of a session when there's not money issues. The bad is there's no money. There's no money conversations. It's already been allocated. So if you didn't have something going on or something allocated during that budget year, there's nothing to really talk about this year as far as new money coming in. I will put one caveat on that. Because of all of the stimulus money and our legislators and the General Assembly having control over that, there may be the opportunity for some new stuff this year, but in a normal world, again, this is something that would have to wait until the upcoming year. And so we're hoping there will be a few new things this year. For those of you that did not follow along last year, when we were in budget talks last year, there was a really, really big concern about budget shortfalls because of COVID and people, lack of taxes coming in, lack of gaming revenue, just a variety of things. And initially, the House had proposed a $30 million haircut for the SUD and mental health budget. And so we were very, very concerned about that. We know that COVID obviously has exacerbated mental health concerns and SUD concerns. We just talked about the increase in overdoses. And so we were really, really glad we had a lot of statewide partners that were vocal to their legislators about the importance of making sure that, hey, we understand the need to trim in places, but just not right now with this. Like we have to have it now. And credit to our state, they responded at the very last minute. The Senate added in all of the money that was going to be cut out. And not only that, they also dedicated $100 million from the stimulus money. The state gets stimulus money. And they dedicated an additional $100 million to mental health and SUD based on the feedback they got from folks like you all, right, at a ground level, calling your legislators saying, hey, we cannot cut these programs right now. It's just absolutely too important. And so there's a hope that there's going to be some direction on some of that money. Most of it will flow through the Division of Mental Health and Addiction for addiction related stuff, just so everybody knows what that will look like in our counties is that they will send out RFPs, requests for proposals. And so they're running it through DMHA to make sure that, because they're the experts in this space. And so they will put requests out for a variety of different things. They've got their own stimulus money from the federal government, but then also the state will be providing some direction as well. And so that's something to keep an eye on this year. The big question again around that is, will they open the budget back up to allocate some of that money this year? And then another thing that's really going to be important, and it's going to come down to a local level as well. If you all have not been involved in this, you probably will at some point, either this year or next, is 988 and the new crisis call line. And so for anybody that's not aware, last year, the federal government passed a bill that required all of the suicide prevention lines across the country to convert to 988. And so that it will be very, very similar to 911. And so the same way that you can call 911 in any state around the country and get, safety net emergency supports, they're creating the same system for suicide prevention and mental health crisis. And so the legislation federally says that all states have to have this done by July of 2022. And so, which that lines up for us at the end of our next legislative session. And so there's a group of people that are working on this diligently. There was a bill passed last year that created a fund for 988. And the goal for the state is to use a lot of the stimulus money to fund the start of this, to the creation of this line, et cetera. But for Indiana, they're really using it as, some states are just see this as a way to like change the phone number essentially. Indiana's trying to use this one-time opportunity with all the stimulus money to change how we respond to mental health crisis. And so it's not just about the 988 line. It's about, okay, if somebody does call in mental health crisis, how do we respond to that with mental health and crisis professionals that are trained in this area? And so they're trying to set up this 988 system right next to 911 where they talk with each other. The mental health call comes into 911, they'll pass it to 988 and vice versa. If somebody calls that's has suicide ideation, that's got a loaded firearm, they will be giving that person to law enforcement so that they can properly handle it. But the goal is to get the right people responding to the right calls. Safety for safety issues, mental health and addiction for mental health and crisis related issues. And so you've got the call line, but then the next part of it is who actually responds. And so that's kind of the gray space that we're in. And then after that, there'll be, and this will be in the next coming years, when somebody does respond, where do you take them? Because if you don't figure that out, you're going to be in the same spot that law enforcement's in, right? Where they either got to take them to jail or the emergency department. And neither of those are financially good moves, nor are they good for the people in question. We need to make sure that we have crisis intervention centers and other facilities that are meant to handle people that are in the state. A lot of times, well, ERs are too expensive and jails can exacerbate the problem, especially if there's not a safety issue. And so one of the things that will be happening this year, they created the legislation in the state last year, created a fund. There's going to be an effort to look at permanent funding for 988, which will probably come the same way that 911 was funded, and that's in the form of a cell phone tax. And so to do 911, I think it was about $1 a cell phone. And so what that does, just so everybody knows, is it generates a lot of money very quickly. And so like, I think that they estimated if they put $1 tax on, that they would probably generate $90 million. And so you start looking, that sounds like an enormous amount of money, but that essentially could be, roughly $1 million a county when it's all said and done. And when you're talking about crisis centers and response teams, it's a good start. It probably wouldn't cover everything. There probably need to be some private funding, et cetera, but that will be a top priority this year for the mental health folks, for the state as well. Along those lines, access to care. We talked earlier about people having access to payer sources while incarcerated. That's a federal rule that you can't, that Medicaid shuts off when you go into jail. And so Kentucky last year sent a waiver request to Medicaid and said, hey, we want to start giving services to people the month before they leave. And so they submitted a waiver and said, essentially, can we do this? And if you guys are going to smack our hand too hard, we won't even move forward in the meantime. And the response to them was, we're not going to smack your hand real hard, but we can't give you a formal response. And so Kentucky moved forward with this, and they have been doing that. And the expectation is that Medicaid is going to respond in January and approve their waiver to start providing Medicaid coverages 30 days prior to release. And so Indiana, the Behavioral Health Commission, for those that you don't know, that's a governor appointed commission that looks at mental health, behavioral health for the future of Indiana. They have recommended that if Kentucky is approved, that Indiana immediately pass a law that directs our state to file for that same waiver so that we can start providing services for people that are 30 days from getting released. I think I should also note there's a federal piece of legislation that would do the same thing that's trying to get passed as well, called the Reentry Act. And so we got people coming at this from two different ways. One, trying to get Medicaid to approve the waivers, and two, changing actual legislation to make sure that we can change these archaic rules. I mean, 75% of people in jail haven't even been convicted of a crime. So like, why are we cutting their insurance off if they haven't been convicted of a crime? So there's a bunch to follow there. And so the 988 piece, the funding for 988, the cell phone tax, the waiver to submit to get Medicaid while people are still incarcerated, so that we can start paying for some of those services, is a big piece. And then we also are looking at, hold on one second. Changes to the hospital payer, healthcare essentially. So I don't know if anybody remembers last year that there was recommended changes to how hospitals could bill for in-facility stuff. For those of you that aren't aware, the price of insurance, the price of hospitals, and the price of prescriptions in Indiana is completely out of whack. We pay a much higher percentage than other states do. And so they tried to change the law last year. All the hospitals completely, for lack of better words, freaked out, right? They were going to lose a bunch of money. And so they've been diligently working with state leaders all summer long about how to get Indiana in line with the rest of the country. And so the Indiana Chamber of Commerce has their legislative preview that happened on Monday. Part of that is that all the caucus leaders are there. And so the Speaker, Houston, was there, the Minority House was there, and then Senate Floor Leader was there, and Minority as well. And they talked about their agenda. And so part of their agenda that on the House Majority side was about this healthcare topic of making sure these prices get reduced, and so that we're better in line with the rest of the country, because we feel like it's way out of whack. Telehealth is another thing that's going to be on the agenda this year. For those of you that are not aware, when COVID came about, the governor gave an executive order that essentially made it so that any services that were done in person could be done telehealth wise. And it made it super simple for everybody, but that was just attached to the executive order. So we passed a bill last year, but it only allowed for licensed clinicians to bill. And for most of you know that there's a lot of other people that provide services outside of just the doctor, right? There's a lot of certified people and other positions that provide services. And so we're going to go back in this year and update that, hopefully, and make it more comprehensive so that people can really offer a full range of services virtually, not just specific, doctor or type, physician type services, so that people can meet with other clinicians, behavioral health folks, et cetera. One thing about COVID is it, threw us into the, it caught us up technology wise to where we should have been a long time ago as far as telehealth goes. And so I'm going to stop there. Those are the biggest ones because I'm about 5 minutes over and you guys do have a few other things to do. And I want to give a chance for some questions. Anybody have any questions about the things that I brought up legislatively, or stuff maybe you know about that you would want, if I know about anything, feel free to put them in the chat box or unmute.
Yeah, this is Rob Priff from Howard County, Brandon. Thanks for what you're presenting. Any info on marijuana legalization in Indiana coming up in this year's legislative session?
So previously, there's been summer study committees on this. And if I'm going to be honest with everybody, the presentations were terrible on both sides. The people that presented that were for it really presented an extreme view of it. And the people that were against it presented a terrible view too, like that essentially the whole world was going to burn down if it was legal. There wasn't a real conversation about it, if I'm being honest. It was just very much a polarized, extreme talking points. Up until this point, up until actually about Monday, no party, both the parties had kept pretty quiet about this as a whole, even including the Democratic Party. And they are fully embracing it this year. Representative Taylor, Senate Member Taylor mentioned on Monday that we have to get ahead of this essentially as far as they're concerned. And by ahead, I mean, Indiana has to get a plan in place. He was not advocating for full legalization, full adult use, but his point on Monday, I don't want to speak for him, but saying essentially that eventually the federal government's going to do something. Every state around Indiana has some type of either medical or recreational use. We're the only one in the middle. We're losing a lot of tax revenue, et cetera. There's obviously other arguments about the increase in addiction, car wrecks, employer related incidents. So this is just me laying out what he said. the majority did not bite on that conversation. They didn't engage in it actually at all. I know the chamber is against it because of workplace issues, but expect it to be a front and center topic this year as the minority party has embraced it. And some Republicans have well. He noted that it polls off the charts for Republicans, Democrats, and independents. And so we're going to have more conversation, Rob, on that topic for sure. I don't
Thanks.
expect anything to happen, just so you know, but there'll
Okay.
be conversation about it. There'll be bills introduced, which is the first part of any legislation, right?
Right,
It's usually
right.
a multi-year process.
Thank you so much.
Does anyone else have any other questions? We're coming up on almost our time. So I just wanted to check to see if anybody has any questions or if they would like to put them into the chat. I did share Brandon's contact information in the chat.
And that's what I was going to say, Kimbra. If anybody does have any questions that pop up, my email's right there. Just shoot me an email. We're pretty knee deep in it from now until March or April. So feel free to reach out anytime and we'll help however possible. So thanks for having me today, Kimbra. Thank you, Katie, everybody. I appreciate it.
Thank you, Brandon. That was great information and we're very thankful you were able to join us. Just a couple other things. If you haven't joined ICN yet, please make sure you do that. And there is the log in on how you can do that. We are also going.
Oops, we lost you.
Bandwidth. Can Katie or Allie discuss the next few agenda items, please?
Kitty?
Sorry about that. So one thing that I wanted to share is that we have actually posted a conversation on the Coalition Network site. It's basically asking for suggestions for 2022's webinars. If you have any suggestions on speakers or topics, this is a good chance to give us your feedback and really let us know what you would like to hear. If you have any big initiatives coming up, something that would be helpful, please let us know. The big thing is that you do need a login, but I've posted in the chat the link to the conversation. And if you needed a login, you can email info@indianacoalitionnetwork.org, and that's also in the chat. So please take advantage of this opportunity because we really want to tailor these webinars to be what you need them to be. Thank you. Allie, do you have any other updates?
No, you've said it. You know, if anyone needs to be onboarded or any assistance, please let us know. Just send us an email at info@indianacoalitionnetwork.org, and we will try our best to help you.
Also, I put in the chat, December's is Wednesday, the 15th again. And I hope everyone has a fantastic Thanksgiving, and we look forward to seeing you December 15th.